today to have Dr. Torrance Andrews from Interventional Radiology to join us. As we have indicated to you earlier in our earlier talks, that approach to the patient for liver transplant is a multidisciplinary approach, and we work very closely and intimately with interventional radiology. And therefore, Dr. Andrews is going to get us through some of the day-to-day work that we do together, and also give us some more information on what they do in radiology to support our efforts. Please help me to welcome Dr. Andrews.
You know, people think of interventional radiology in surgery and mostly think about abscess drainages and things like that. And since the transplant surgeons here never get any abscesses, it's a good thing that we actually have some other things to do. Interventional radiology is actually involved in the management of transplant patients from well before they actually get the transplant throughout their experience. Starting with some things that we do pre-transplant. It's a little dark. Yeah, thanks. I can't see the keyboard. Beginning with things that we do before transplant. You know, the workup of patients for liver disease and for kidney disease involves biopsies on a regular basis, and generally biopsies are performed percutaneously with or without image guidance, generally by the hepatology service or the nephrology service as appropriate. But it's not uncommon for these patients, these complex patients being worked up for transplant, to have problems that make it difficult for them to have percutaneous biopsies, ascites, coagulopathies, thrombocytopenias as listed here. In addition, there are patients who are complex enough that they need more than one thing done at the same time. So patients who have liver disease and are being considered for concurrent renal transplants will frequently have renal biopsies. And patients who have end-stage renal disease will often need to have a tunneled catheter or other vascular access device placed concurrent with their biopsy. So in those patients, we have the opportunity or the option of doing percutaneous biopsies. Doing transjugular biopsies. The advantage of doing a transjugular biopsy is that there's no need to cross the peritoneal space. There's no need to breach the capsule of the organ that you're biopsying. You're not dependent on adjacent structures, so if you have a patient who, for instance, can't roll over into a position that would tamponade your access site, you have a lower risk if you use a transjugular approach than a percutaneous approach. And we have the ability to do concurrent procedures. So this is the schematic of a patient who's having a transjugular renal biopsy. The device is passed through the jugular vein under ultrasound control. There's a rigid cannula that's demonstrated in this slide that advances into the renal vein, and then through that we do a coaxial core biopsy. So some pictures from a sample case. You can see the device coming down through the inferior vena cava and into the renal vein. There's a little bit of contrast being injected to verify that we're in an appropriate position. And then in the image on your right, you can see the biopsy needle has been advanced across the parenchyma and is ready to take a core. We reviewed our experience with transjugular renal biopsies at the University of Washington last year, and just briefly to run through it, there were 70 cases done in 62 patients. The INR was as high as 5.6. The platelet count was as low as 29. The patients had both abnormal clotting factors and thrombocytopenia. There were 17 of those. 2 patients were treated with transjugular biopsy because of their body habitus, and 13 patients were treated with a transjugular approach because there was a need for another procedure. We used the right internal jugular vein most of the time. A couple of times we went through the femoral vein, once to do a biopsy of a transplanted kidney, and once because the anatomy of the renal vein was such that we couldn't access it from the jugular approach. We use a little contrast, as I mentioned, but only 28 cc's on average for this patient population. The concurrent procedures were vascular access in 6 patients and concurrent procedures in the liver in 5. And our outcomes, or our experience, was that we had transient self-limited extravasation in 7 patients. We only had hemodynamically significant bleeding in 2, and that is patients who had hypotension, and tachycardia. One of those patients required a transfusion. We had transient hematuria in 3 patients, and we had clot retention in 2. So if you consider clot retention and hemodynamically significant bleeding to be major complications, our major complication rate was 5.7%, which is pretty good when the patient population we're working on is one that is clearly predisposed to having complications with a biopsy procedure. So this is an example of the transient self-limited extravasation. You can see a little bit of contrast here, puddling outside the kidney. It persists a little bit into the later phase. And on the unsubtracted spot film, you can see a little blob of contrast there. So that's a fairly typical thing that we see. But, you know, again, that's a self-limited process that doesn't require any treatment. We had diagnostic glomeruli in 86% of the samples viewed by light microscopy and 71% that were sent for other studies. And we also found that there was quite a bit of variation among operators, but the most experienced operators got diagnostic material about 90% of the time with this approach. So, other things that we do before transplant, bridging therapies. These are important because although the transplant is the major event that happens for the patients, the transplants take a long time to happen, and in some cases may never happen. So it's important for us to help to maintain the patients before their transplants go forward. And in many cases, it's only because of procedures that we do in interventional radiology that the patients are even transplant candidates, and I'll talk about those. Sort of fundamental things for renal patients, we maintain vascular access or hemodialysis or peritoneal access for dialysis. For liver patients, we can manage fluid collections, decompress the portal vein, and do various procedures to keep liver tumors from getting out of control and pushing the patients outside of transplant criteria. So just kind of running through those in sequence, peritoneal dialysis access is traditionally done surgically. You make an incision, you put the catheter in under laparoscopic or direct vision, stitch it closed, and wait a little while for the access sites to heal, and then you're ready to go. But you can also do it percutaneously, all with local anesthetic and small punctures that don't require a healing time, so these can be used immediately with very little risk of complications. And I'm not going to spend a lot of time talking about these 2 studies, but both of them basically showed that a comparison between the percutaneous approach and the traditional surgical approach shows that the outcomes are similar or better for the percutaneous approach. And in fact, this author concluded by saying percutaneous fluoroscopically assisted placement of peritoneal dialysis catheters should be considered when available and may be preferable to other methods. Now, sometimes the problem isn't getting fluid in and getting it back out again, as in peritoneal dialysis. Sometimes you just have massive ascites in patients who have liver disease or renal disease, and the goal is to get rid of their accumulation of ascites. You can do that with multiple paracenteses, or you can put in a tunneled drainage catheter. This is one example. There are others. These are basically introduced like a peritoneal port or a peritoneal dialysis catheter. They have a valve at the end, and when the patient feels fluid collecting, he or she can simply drain it into a little bottle. And that is, I think, definitely preferable to doing multiple paracenteses for the patients, especially when they get to the point where they're needing paracentesis every couple of weeks. Now, a better way to manage patients with intractable ascites, if you can do it, is the TIPS procedure, the transjugular intrahepatic portosystemic shunt. I think most people are aware that this is a minimally invasive alternative to traditional surgical bypass, and it's been around and in use since about 1985. Just a quick couple of slides to demonstrate what this is involved, or what's involved in this. This is a patient who has portal hypertension. You see that there is retrograde flow through varices here in the coronary vein, and also recanalization and retrograde flow in the umbilical vein. When you do a TIPS procedure, you advance a needle across from the hepatic vein into the portal vein, you dilate a tract, you put in a stent, and when you've put in the stent, you reestablish antegrade flow through the portal vein. The varices, either spontaneously or with concurrent embolization, will close down, and you reestablish a much more normal physiology in the mesenteric venous system, so ascites can improve or resolve, and bleeding similarly can improve or resolve altogether. Just a couple of slides from an actual case. This is a patient who has large varices in the coronary vein distribution, and we've got a catheter that's now been advanced across the portal vein, across the liver parenchyma into the portal vein. Here's the same patient after the stent has been placed, and you see that the varices have resolved. So fairly typical pre and post TIPS appearance. The indications for TIPS include basically anybody with intractable portal hypertension that's symptomatic, especially a patient who is a poor surgical candidate. So that would include patients with varices that are bleeding and unresponsive to other treatments, patients with portal gastropathy who are bleeding, patients with intractable ascites, as I mentioned, and in some studies, people have had pretty good results in treating hepatorenal and hepatopulmonary syndromes with TIPS as well. Outcomes are good. Technically, we're successful these days almost every time. We are able to control variceal bleeding immediately almost every time, especially if we do concurrent embolization. We're not quite as good at controlling ascites and even less effective in controlling hydrothorax, but still, as you know, it is possible that the likelihood of improving intractable hydrothorax is at least 50-50. And for patients who are dealing with that condition, those are pretty good odds. The risks are relatively low. You can obviously have a direct injury to the liver. You can cause hepatic ischemia with worsening of liver function. You can get encephalopathy because by bypassing the liver parenchyma's first pass clearance mechanism, you can increase systemic nitrogen levels. And you can cause communication with the biliary system, which can cause bleeding or infection. But all of those are pretty uncommon. If you look at the rates of complications that are listed here, I would say that in experienced hands, you're looking at the bottom number there for almost all of the complications that are listed. The one exception to that is hepatic encephalopathy. It's pretty common to get transient encephalopathy after a TIPS, especially among patients who have a lot of blood already in the gut from GI bleeding because they continue to digest that blood over several days, and you've removed their ability to clear nitrogen from the mesenteric venous system. So typically they'll get worse, or they'll have pretty significant encephalopathy in the first few days. But uncontrollable or irreversible encephalopathy is very uncommon, and if it occurs, you can always shut the TIPS down. Not many contraindications. If the liver's already so sick that it's just barely getting by, then making it even a little bit ischemic may be a significant problem. So generally we won't do a TIPS if the bilirubin is over 6. If they already have intractable encephalopathy and you can't attribute it to the bleeding that you're trying to fix, then a TIPS is probably not a good idea. If the hepatic artery is occluded, a TIPS is not a good idea because you will definitely make the liver ischemic with that procedure, and that can be an unrecoverable problem. And there are some other things that are listed there that I think are pretty obvious, but generally we can work around almost all of these issues.